of Orthopaedic Surgery East London University. ويعني من الشرف لنا كمصريين ان الدكتور محمد إمام من الاكثر 70 شخصيه اللي تم اختيارهم المؤثرين في التاريخ العلمي لمصر، وين الزملاء الطيور المهاجره المغتربين بره مصر. دكتور محمد طبعا له بصمات واضحه في جراحه العظام سواء في انجلترا سواء في مصر، وشرف لنا ان هو شرفنا في العديد والعديد من البرزنتيشنز in our course. فانا طبعا يعني من كل قلبي بشكر حضرتك على الايادي البيضاء اللي حضرتك على الكورس التدريسي لنا برعايه جمعيه جراحه العظام المصريه. دكتور محمد بيه.
Thank you. شكرا دكتور محمد.
شكرا
Thank you very
جزيلا.
much for the lovely introduction, and it's a pleasure to be with everyone. And actually, I totally understand how hard it is to arrange for such an dedicated course by yourself and the team at Penha University. It's a pleasure always to be with you, and it gives me utmost pleasure actually to talk about anatomy examination and biomechanics and rotator cuff disease, and including reverse shoulder replacements as per our discussion. It's a privilege to be with everyone and the elite panel you keep inviting to your very well-watched and now renowned course. So I'm going to simply talk about shoulders for the next half an hour or so. So our demands as humans have evolved significantly. However, our shoulders didn't. And that's the problem we're having now. Nowadays, we have, when you see a patient with a shoulder problem, you have to understand the complex nature of the problem. The shoulder, for sake of mobility, stability has been sacrificed. And when we talk about shoulders, we talk about the glenohumeral joint, which is the main joint, acromioclavicular joint, which is a joint where problems are increasingly happening nowadays, and the sternoclavicular joint as well. And most importantly, the underestimated joint, and a very important joint, which is a physiologic joint, the scapulothoracic joint. So in shoulders, muscles constitute the huge importance in the shoulder function. And this includes the bulky deltoid muscle with the anterior, middle, and posterior bands, and more importantly, the rotator cuff muscles, which is crucial for the function of the shoulder. And we're going to be discussing the rotator cuff in details in this talk. And the function of the rotator cuff is to keep the center of rotation in front of the ball, in front of the socket. And that's why when you have a tear in the rotator cuff, there is superior migration. What near coined as cuff tear arthropathy happens, and that causes pseudoparalysis of the joint, and ultimately that shoulder function will be seriously affected, causing significant problems. So what do we do in shoulders? You know, the shoulders does sliding and rotating movements, and in order for the shoulder to do this movement, we have to have normal balance, and that normal balance is achieved through the different parts of the muscles we've just discussed. When I see a patient with shoulder problem, I'll go through the way I approach these patients. You have to understand the complex pathology we have in our shoulders and the complex nature of our patient. The way you treat each patient should be dependent on their functional limitations and the function demands as well. And subsequently, let's have this example. You have a 75-year-old patient with pain in the right shoulder, started when he was 35 years old. He had subacromial decompression, and he's still having shoulder pain for 10 years. Whatever the patient, I approach them at the same way. We've coined the concept of diagnostic clusters. We know that you can get most of the diagnosis just by history and examination, as Professor Al-Ashab would be teaching his students in Penha University. First question I ask is, where is the pain? And actually, by answering that question, you can tell what is the most important findings in this assessment. And this picture is actually from Diagnostic Cluster book by my good friend Puneet Munga. So then what is the rotator cuff disease? It is a cascade of problems that happen over the years, and patients can skip one and jump into the other. And we'll go through different assessments there. But all these problems, patient will have pain at the insertion of the deltoid tendon with pain referred distally. So second question I would ask is there a history of trauma? Because if there is history of trauma, you should suspect instability, fracture, or a tear. If it is all trauma, I'll be worried about frozen shoulder. But if there is no history of trauma, it will be a degenerative problem. Second question, how old is the patient? Because if a patient with trauma in young age group, 99% is a fracture or a dislocated or recurrent instability of the shoulder. If there is no history of trauma, I'll be worried. It can be cancer or infection. Middle age group can have anything, and the elderly, it will mainly be degenerative problems. So I then ask the patients to move forward flexion, combined abduction, external rotation, and then internal rotation. And when I do that, I need to answer two questions open my assessment. This would be, is there stiffness? And if yes, where is it stiff? Is there a limitation of passive and active range of motion? If yes, that would be frozen shoulder or arthritis. If it's only active, that would be a rotator cuff tear. So it's a problem there. Actually, if they are limited in passive and active range of motion and you can feel crevitus, it's always arthritis until proven otherwise. And then, where is it painful? Pain at rest can be frozen shoulder or arthritis. If it is mid-arc, it can be impingement or cuff tears, and you can see between 60 to 100 degrees, this is there is pain in the subacromial bursa because this is the least space available for shoulder motion. And if there is pain at high arc, then I'll be suspicious of an acromioclavicular joint pathology. And so I then move the patient and start doing my assessment. You can do the impingement sign. A quick test would be the Hawkins-Kennedy test, in which the shoulder is bent 90 degrees, elbow bent 90 degrees, and you do internal rotation. And then I move the arm to the other side with cross-chest movement to test for acromioclavicular joint pain. You can do the resisted extension pain, and if there is pain at the acromioclavicular joint, this is indicative of acromioclavicular joint pathology. And then you have to assess the tendons. And in the shoulders, there are a huge number of tendons contributing to the function of the shoulder, ranging from biceps tendons, rotator cuff tendons, pectoralis major and minor tendons, as well as the trapezius. Also, I test core stability because it's really crucial for shoulder function. And the most important as well muscle in the shoulder function would be the deltoid. And we'll come to that later on. So let's start with the assessment of the rotator cuff. With the assessment of the rotator cuff, you need to do the empty can test. We're doing an actual modification where you do the empty can test and a bit of adduction. That actually is significantly more specific, and we're writing our findings in that regard. And then you test external rotation, which is main external rotator infraspinatus, as well as teres minor. One test you can do would be drooping signs. So you put the arm in external rotation, and if it fails, that means the main external rotator infraspinatus is not working. You test also the other external rotator, which is the teres minor, which mainly function in abduction. And if the patient cannot keep their arm like that, it falls off. And that's important as well in my shoulder replacement patients, because if I find that problem, I do Lebesco transfer with my procedure. And then there's the main internal rotator, which is the subscapularis in internal rotation. On the right side here, you can see the Gerber's left-off test. And here you test with the Bear-Haggard test. long head of biceps is an important generator of pain in shoulders. On the left side, you can see the speed test. Arm is extended, flexion and supination, and if there is pain at the long head of biceps, that's diagnostic of shoulder problem. A Yerkson test where you do resisted supination, and if there is pain flexion, when there is pain in the long head of biceps area, that's also diagnostic. And you always have to make sure the patient doesn't have instability. And it's crucial to look at scapular dyskinesis, because this is an important pathology that shouldn't be missed. And it is crucial to look at, there are different causes for abnormal blade movement, traumatic and atraumatic causes. This is a summary of these causes, but it's crucial to keep that in mind. And that's why when I'm examining shoulders, I look at the patients from the back and exclude abnormal blade movement. And you can see that the minute you look at the patient from the back, as you can see in this video. So it's crucial as well to examine the neck. One possibly of 8 patients, every 8 patients I see, the main problem is actually in the neck, not in the shoulder. And actually you find patients with problems in the neck and the shoulder at the same time. And it is important to understand that. Whenever you see any patient, you have to remember the 3 P's. There is a problem of the pathology, the problem of the patient, and the problem of the participation and what your patient wants. So back to our problems. So patients with impingement, they will have pain, painful arc, and the impingement test. And then you treat them with physiotherapy, steroid injections, or posture correction, which works in most of them. There is a lot of programs on my website. If you want to download any of these, please feel free to do so and give it to your patients. So another important thing that you can see in these patients as well is I tend to do x-rays for all my patients, because if for the previous patient, if you do an x-ray, you can see huge calcific tendinosis, as you can see. And if that's the case, we tend to do parpotage, which is an aspiration using ultrasound guidance. But if that fails, then we opt for surgical release and release of calcium. At some stage, the calcium can be like a toothpaste, as you can see here, or it can be choke-like. So both are important for identifying the diagnosis and managing the problem. Some patients will have, and as part of natural history, some of these patients will have partial thickness, and then when you test for partial thickness tears, and then when you test for the rotator cuff tendons, you will find that the tendon is weak. I tend not to inject steroids if someone has a partial tear, because I've seen in a lot of my patients who had steroid injections for partial thickness tears, they come back with progressive tears when you repeat the scans. And so I tend to manage them physiotherapy or arthroscopic repair. One good option nowadays is the biologic patch by Smith and Nephew. We're currently doing a randomized controlled trial looking at comparing it to repair. And in this biologic patch, all what we do is actually sticking the patch and clipping it to the top of the tendon, and we're collecting our results. And actually it is a very good option for managing partial tears, but still repair either by completing the tear and repair, or repair in situ are still very valid options for these partial thickness tears. Maybe the advantage of doing the option is actually the that you keep them in a sling for just a few days after surgery. Finally, if patients develop full thickness tears, you can try physiotherapy in degenerative tears, but usually arthroscopic repair is a good option, especially for traumatic tears. And age is not one of the parameters which makes me consider whether or not to repair. what really matters is the fatty infiltration and the size of the tear. And subsequently, I'll always opt for arthroscopic repair. And we published many papers looking at different outcomes. And we found that if it is a large tear, it is better to opt for double row. And we opt for single row if it is a small or medium tear. We did this RCT comparing two different techniques at 3 years from surgery. And we found that both are the same for small to moderate tears, while double row is actually more favorable for large to massive tears. So other options, tendon transfer, either latissimus dorsi transfer or lower trap transfer, or the other option, which would be the superior capsule reconstruction, which is a good option. I am now preferring more to do the lower trap transfer, and especially it is a very good functional transfer that you can see here. One of my patients, doing the lower trap and fixing the tendon Achilles into the shoulder is a very solid option for irreparable tears, and it is a dynamic option that patients are actually doing very well after this kind of surgery. And you can see the tendon Achilles graft connected to the lower trapezius muscle on the back there. So we have huge amount of options for tears, massive and irreparable tears. So what happens if we don't repair? If we don't repair, there is proximal migration of the progressive failure of the cuff, proximal migration of the humeral head, and ultimately a patient will have cuff tear arthropathy. And we can still manage it with physiotherapy, and we have different replacement options, not for cuff tears, but I mean for replacement, either resurfacing, hemi, total, or reverse. For cuff tear, we have also the custom-made options. So what happens in cuff tear arthropathy? So Hamada classification, which is the most popular classification that we use, which actually grade the problem according to the displacement of the humeral head and the radiologic changes that happen there. And irreparable cuff without arthritis, it's either superior capsule reconstruction of the infraspinatus and the subscapular intact, or a tendon transfer like lower trap transfer like the one I've shown you, or a reverse shoulder replacement. And reverse shoulder replacement, it happens because we need to understand the problem. Because what happens here, when you have a tear, the tear increases in size and there is progressive narrowing of the subacromial space with superior migration of the head, causing significant arthritic changes, as you can see in that video. And the disadvantage would be shortening of the deltoid muscle, and the only option we have if there is arthritis would be physiotherapy and obviously a reverse shoulder replacement. So we start with physio. If it doesn't work and there is no arthritis, we do SCR or the tendon transfer. My preferred one is actually the lower trap transfer, like I've shown you. And eventually, if all fails, we can go for a reverse shoulder replacement. So we'll quickly go through reverse shoulder replacement history. Charles Neer was the first one, and many would regard as the godfather of shoulder surgery, one of the earlier godfathers of shoulder surgery. And he designs the Neer implant. The problem with Neer implant is if it is conventional OA and the tendons are intact, patients had good results. But what Neer didn't understand is the video I've demonstrated to you earlier. When you have cuff tear, you have cuff tear arthropathy, progressive proximal migration causing significant deterioration in function. And then it was Gramont who actually worked on different concepts of how to improve things. Historically, there has been a lot of work over the years in order to design implants in the shoulder, learning from the advances of hip replacements, trying to redo hip replacements in the shoulder, and there was significant failures over the years. You can see a lot of implants that was designed, and the main problem was we cannot reproduce shoulder function by just replacing anatomically, and all failed because there was excessive torque and shear forces at the glenoid component bone interface. It was Zaban 1985, where we owe a lot to Gramont from France. He thought about a medialized center of rotation and distalization of the humerus to decrease shear forces on glenoid component bone interface. And he thought that in his implant, if you increase the moment arm, the function will improve. And he has demonstrated that over the years. And it is simple. Looking at this video, if you do a convex glenoid and a concave humeral component, you increase the lever arm of the deltoid and make increasing the force and increasing the function of the deltoid. So without the compressive force of the rotator cuff tendon, you move the center of rotation medially and distally, increasing the moment arm of the deltoid, enabling deltoid to be at an advantageous lever arm where it will contract and cause abduct the shoulder fully. And if you do so, you don't need an intact cuff, as you can see on the left side. The other things that we found when we did this is Roche did this nice paper. The main problem they found is actually the notching, which happens there in this Gramont design. And the other problems that we found as well with the Gramont design over the years is that if you elongate the deltoid so much, you can have other problems. One of these problems would be acromial stress fractures as well as cosmesis, because you can see that the patients lose the rounded shape of their shoulders, which is disadvantageous cosmetic-wise for some of our female patients. But with the Gramont, you put the subscapularis a bit inferior, and that enabled that also Gramont didn't have significant improvement range of motion rotational wise. So the indications of reverse shoulder replacement now are huge. And mainly the main indication still is rotator cuff arthropathy. And we looked at different results. We published this paper as salvage option for failed replacements. We looked at 159 reverse shoulder replacements at 5 years follow-up, and we found that reverse shoulder replacement is a very forgiving replacement. It can serve as an excellent revision implant for fixation and for others, but it should be used wisely, because at some point you might have significant complications and the salvage there is not huge. And main contraindication would be deltoid deficiency, although you can do combined tendon transfers with reverses, and definitely active infection is a contraindication. Finally, what do we do when we have a patient with reverse? I have actually with arthritis, and I'm planning to do it. Of course, X-rays is crucial. CT scan is mandatory because it gives me a great idea about the bone structure. Also, I measure the glenoid versions. There are different ways of measuring. So we publish this ellipse modification where we look at the scans and decide from that, we measured the version and we find this to be significantly better than the Friedman method. Nowadays, we do MRIs just to assess the tendon quality, although I rarely will do an MRI if I'm planning for a reverse shoulder replacement. It's crucial now that with the current implants, we have different options, different planning programs that enables us to identify the components, whether we need bone graft or metal implants or any specific components while doing these processes. You have to choose your approach. Personally, I'm a big fan of the deltopectoral approach. It's an extensile approach that enables me to access different aspects of the shoulder. It is extensile, so you can extend it. So I can do an deltopectoral approach all the way from the deltopectoral space up to the lateral humeral condyle distally in case of fixation. If you have a fracture while doing your shoulder replacement, you can access distally and fix that fracture. Usually the long head of biceps is our entry point. You have to be extra cautious with the axillary nerve. We did a cadaveric study and we find the axillary nerve is most at risk, actually inferior aspect of the glenoid. Taking a stay stitch in the subscap is important if you would like to repair the subscap later on. Defining your spaces. I tend to do pony peel now whenever I'm opening the subscapularis tendon while doing shoulder replacement. We have different components now and you have to decide which one you will use, but personally I would prefer the deltopectoral approach. So what sort of components you can use? We discussed the Grammont, and the problem with the Grammont was always notching, rotation, and stability. And then this surgeon in the US has popularized the lateral components. So we have now two lateralization. You can either lateralize your components through the glenoid or the humerus. And many surgeons, including myself, have moved from the Grammont design with medialization because of risk of decreased rotation. Patients are not happy with the rotation after surgery, notching and failures. And now we go for lateralization. You can lateralize your components either through the glenoid, either using bone or metal, and you can also lateralize it through the glenoid or through the humerus. And to lateralize it in the humerus, you can either use an eccentric tray, curved stem, or reduced neck shaft angle. So we have a lot of replacements. We have multiple options now. We are gaining significantly better results with reverse shoulder replacements, and actually it is becoming commonly performed nowadays. You look at registries and you find a lot of patients have been having significantly good functions. The number has significantly improved over the years. So we have three concepts now in reverses. The first one on the left side is the Grammont type, where you have a medial glenoid and medial humeral design, which was the original design. As I told you, the main problem with this design was glenoid notching as well as decreased rotation. Also, because it is overly medialized, you can have other problems like acromial insufficiency fracture or so. The angle used here is 155 degrees, and still we have a long-term track record for this design. And this has been put in shoulders from the 80s after it was designed by Professor Grammont. Problem with it as well, you distalize the rotator, the notching, which you can see the rubbing between the humeral side and the inferior notch. And then one option was to do lateralization through the glenoid, either with the same medial humeral design. You can do the lateralization either with metal augment or with poly augment, or with the design like having an eccentric tray. That actually reduces the notching effect of the components, but it increases the stresses on the glenoid component. It decreases the lengthening of the deltoid, so it is associated with improved functions. And there are many designs nowadays commonly used which involve lateralization of the glenoid component. And finally, we can lateralize through the humerus itself. And by lateralizing through the humerus, you take a bit of advantage from the glenoid component, from the medialization, because you don't have increased stresses and torque on the glenoid because the glenoid is still medialized, but you decrease that. And then you actually reduce the angle to 145, and having the angle there would enable you to prevent notching, as you can see, without causing stresses at the glenoid bone interface. You can do that with a lateral, with eccentric stem or curved stem, and there are different components in the market now looking at that. So advantages of glenoid lateralization, that you have less notching, better rotation, better shoulder contour, and better stability. But you get reduced abduction, although that's no longer a problem, I think, in my patients, and you can have the risk of glenoid notch loosening. If you go for humeral lateralization, you still have better rotation, less arm lengthening, less notching, and better shoulder contour, but you have reduced abduction and query instability. We look at revisions using shoulder replacements with paper led by Christian Gerber, and we looked at 48 patients with periprosthetic joint infection, and we found that actually infection is a hard problem to treat, but usually it is successful. We looked at 159 of reverses that we've done using lateralized component, and we found that it has significantly improved function in these patients. Favard have looked at reverses with cuff tear arthropathy, and they found that the improved function is maintained over the years. So what's next? So bio-RSA, by Boileau, simply lateralizing the component with bone so that you don't have glenoid bone interface stress loading, and get the advantages of the lateralization without the loosening element of it. But we looked at the proposed advantages by undertaking this systematic review, and we found that better scores possibly can be achieved as per different bodies and by doing meta-analysis. And we looked at different scores used, but none of the published papers have demonstrated that there is significant improvement of scores. And then we looked at the proposed advantage of better rotation, and we found that possibly external rotation was there. We looked at the proposed advantage of less notching, and we found that actually there was reduction in notching. And we ask ourselves, does the graft heal? And actually the evidence is promising in that regard. So the graft heal, there is reduced notching. There might be some improvement of rotation, but no one has demonstrated that there is better outcome scores. So what's next? Also, navigation is important, and we are actually doing a study on, there are different virtual reality systems now. This is the one by Tournier, Right Medical, or now Stryker, and it looks, this is the way it looks. Medacta also have a system which we trialing now with having augmented reality and having advanced planning. So when you have, so you can have this navigation system, and with virtual reality, as you see on the other side, you can decide where is the best point of rotation, where should you stick your central pin. When you're doing this, you can see as well how long you can keep your screws and your pegs with virtual reality all live. All what is needed is a CT scan done, including the elbow. And then by deciding the best orientation to fit the matched orientations that you found on the preoperative scanning, you can achieve the best version. It's crucial as well for screws. As you can see on the right side, you can decide where you can put your screws for better purchase and better orientation of the problem. And then finally, if you also were to aim for your base plate in order to achieve the best coverage in the right rotation. So it is worth investing. There are advances on daily basis with shoulder replacements, and we now every year we understand shoulders more work still needed. Finally, we have to keep looking at our own scores and our own outcomes, and eventually, you know, this is a few of this was done by my colleague Ali, and we can achieve more. Thank you very much.
Thank you so much, Professor Imam, for this very valuable and very interesting talk. من الحاجات اللي عجبتني قوي في كلام سعادتك يا دكتور محمد بيه ان look at the registry and you will find the results of different prostheses and different designs. I think we have to have our own national registry in Egypt.
Of course.
وانا طبعا ده مهم جدا دكتور محمد بيه.
Yes.
وانا كلمت فعلا يعني جمعيه جراحه العظام ان احنا we have to have our own registry، وهم طبعا اساتذتنا هناك يعني متحمسين جدا، وان شاء الله احنا هنمشي فيها، لان دي يعني هتطلع لنا كم من الريسيرش فوق الوصف يعني.
Definitely.
بالظبط.
And actually it is being adopted everywhere. The point as well with registry, it gives you an idea about what's happening, because we as surgeons are biased. We think we're doing great jobs anyway, but you know, but the point is we can pick up badly performing prostheses over a long time, and then we can understand why these prostheses are not doing well. Pick the bad performing ones, pick also surgeons who are not doing the best jobs, and actually ultimately it will help our patients.
Yes, sir. Thank you, sir. We have a question for you, sir, from Dr. Mohamed Mamdouh. You prefer to repair subscap or not, sir?
So actually, it's a great question, Mohammed, you know, and it's a very debatable question in shoulder arthroplasty. I tend to repair it just as an extra cover for replacements, but when I go back in revision surgery, and even in cases where I know that the subscap was repaired, it's usually not functional. And if you look at it as well for mechanics in reverse shoulder replacements, they will do fine without subscap repair. So I think it's debatable, but you know, if it is frail or it's just a thin sheath, which I know it will be doing nothing, I can actually skip repairing it.
Yeah, thank you, sir. If we have any other questions to Professor Imam. طيب احنا هنستأذن حضرتك لو نعرف in brief عشان يعني ما ناخدش وقت حضرتك، يعني الستبس اللي اي حد عايز يكمل البوست جراديوت ستادي او ياخد جوب او يكون له فرصه للعمل في انجلترا، what he has to do.
It is, you know, nowadays there are a lot of Egyptian and actually overseas doctors in the UK. I'm an examiner in the PLAB exam itself. I think actually it is easy to pursue a career in medicine in the UK. It depends on what's your ultimate target. So if you want to come and just do a fellowship or a condensed program, you have to have the exam, you have to be registered in the GMC, because I see a few people coming from overseas and they actually just sitting in theaters or standing in theaters observing what we do. And actually it wouldn't be very beneficial if you're not scrubbing, because we learn as surgeons from scrubbing either by observation or by actually doing stuff. And so I would highly recommend that. There are 3 ways where you can actually come to the UK and work. One is actually doing the PLAB exam, which is an easy exam. So, or second way is doing MRCS or international FRCS, and you can also get GMC registration through these 2. Or there is an option called MTI, so you can contact a surgeon where they are participating in the training initiative, and then the Royal College of Surgeons can sponsor you for that. The problem is there are also the finances. So you need GMC registration in order to get paid by hospitals, because you have to do work in hospital so that they pay you. Or if you're going to be paid by Egyptian or any overseas institute, or you're going to self-fund yourself, then that's a different thing, but it will usually be an observership. The UK, like any other country, needs a lot of doctors nowadays, and definitely, there is great potential nowadays for that. You will have to do an English test, either OET, which is an easier test now, or the IELTS, which is also a great test. If you're a fresh graduate and you want to work in the UK, then you need to do the PLAB, come do junior jobs and progress, either through a training number, or you can, if you have some experience, you can do non-training jobs, but you will ultimately have to do the exams, the FRCS exam, and get registration through the CSER route, or get the CCT if you are a trainee.
Yeah, is it easy to do, sir?
A PLAB test is very easy. I examined a PLAB test for the last few years. It's an easy test. All what you need is part 1, which you can do in British Council in Egypt or any country, and PLAB 2 you have to do it in the UK, and it is an easy test. It's actually for a house officer level, so it should be easy for anyone with sensible knowledge. And you have to do the English test as well initially, and the English test actually is not difficult now with the OAT.
Yeah. Thank you, sir. We have a question for you, sir. هل تقوم حضرتك بإعادة تثبيت الانفيرس مع الروتيتور كاف ارثروبلاستي؟ وما رأي حضرتك في إعادة التثبيت؟
Subscapularis or the rotator cuff tendons?
He didn't mention, I think, a rotator cuff.
So in reverse shoulder replacement, you don't need the supraspinatus and infraspinatus anyway, because they are actually, I release them even if there are. Now there is a bit of a trend on doing reverse shoulder replacement for anyone above the age of 75, because we know the rotator cuff is not functional and we know it will fail anyway. So we don't do anatomics. But if I had a young patient where I did an anatomic shoulder replacement, I'll definitely have to have sound rotator cuff for that. There are some evidence saying you can go repair the cuff in this young age group and do a reverse shoulder replacement. And definitely I do double row supraspinatus repair in total anatomic shoulder replacements, because it is crucial for the function. But for reverse shoulder replacement, we don't really need to repair the rotator cuff, and the evidence is clear as well, because it mainly depends on increasing the lever arm of the deltoid muscle. What I tend to do, I test external rotation by doing the Hornblower test. So if the teres minor are not functional, in reverses, I'll do lepescope transfer. So I'll move the latissimus dorsi and make an external rotator. And that I do routinely in these patients. And the outcomes, we're looking at the outcomes. We don't know whether it is needed or not, but there is a bit of a general consensus in doing so nowadays.
Yeah, thank you so much, sir.
Thank you.
Finally, I would like to thank Professor Mohamed A.Imam, the Professor of Orthopedic Surgery, East London University, for sharing with us his experience in his very precious time. Thank you so much, sir.
Thank you, Professor Mohamed, and wish you the best of luck in the coming elections in the Egyptian Orthopaedic Association. I think you'll be a great addition.
Thank you so much, sir.
إن
شاء الله احنا الجمعة الجاية لقائنا مع حضراتكم مع German experience in spine surgery مع two eminent professors في Germany. they will speak about spine problems. فان شاء الله نشوف حضراتكم يوم الجمعه الجايه الساعه 9 مساء باذن الله. وعذرا يا دكتور محمد بيه ان انا عارف ان حضرتك يعني سو بيزي وان وقتك ما كانش يسمح بالمحاضره النهارده، فاحنا شاكرين يعني ان حضرتك استقطعت جزء من وقتك للمحاضره الجميله دي يا فندم.
It's always a privilege and a pleasure to be with you.
Thank you so much, sir.
Thank you.
Thank you. تصبحوا على خير يا فندم. Thank you so much, sir. Thank you.
Bye-bye. Thank you, Dr. Mohammed.
Thank you, sir. Thank you, sir.
Take care. Salam.